Thank you for those of you who are logged in for joining me this evening. We're going to go over a presentation regarding Fertility 101. I always say I wish we had health class as adults, because when you learn it when you're younger, it doesn't matter, you're not paying attention, but it's really, much more meaningful as we get older. So in terms of what we're going to cover today, of course, I'm Dr. Ressler. I'm part of Illume Fertility. We are a comprehensive fertility practice. We have 5 locations, 4 of which are in Connecticut and 1 in Westchester, in Harrison, New York. And we are comprised of 9 board-certified reproductive endocrinologists. We have an on-site surgical suite. We have laboratories in each of our locations for andrology services. And we have many certifications and really a great program, the Integrated Fertility Wellness Program, offering other services as well, which I'll get into in a little bit. So in terms of what we offer fertility assessments, egg, sperm, and embryo freezing for fertility preservation purposes. We offer both IUI and IVF treatments, donor and donor egg, donor sperm, and gestational surrogacy services. And then part of this integrated fertility wellness program, we have acupuncture services, counseling, nutrition. We have 2 registered dietitians in our practice and different support groups. So lots to offer. So now let's get into, the topic of this evening, which is Fertility 101. So what is infertility? Actually, the definition was just updated this past year by the American Society for Reproductive Medicine as needing medical intervention in order to achieve a successful pregnancy, either as an individual or with a partner. So this new definition is really more inclusive than prior definitions, which used to be after attempting conception after 1 year without success, or 6 months if a woman is 35 or older. So what are the building blocks for conception? We really need 3 main parts. We need the eggs, we need the sperm, and we need the uterus. These could be from one couple, it could be from others outside of that couple, meaning third-party reproduction. There are all different ways, to utilize these different parts. But just let's go over the basics of female anatomy. I always like to review just the basics first, so that we have a good understanding both of the anatomy as well as what happens in a regular cycle, because everything we do in terms of treatments is really just a manipulation of what happens naturally. So the basics, female anatomy involve the vagina, the cervix, which is the entry into the uterus. These are fallopian tubes and ovaries. So it's inside of the ovaries where our eggs are stored, and we can't see them because they're microscopic, but we know that they're living and stored there in our ovaries. Okay, and so what happens is every month there's a group of these eggs available for use. These eggs are contained within little structures called follicles. Okay, so I know there's a lot going on this diagram, but again, this is what happens in a natural cycle. So just having a basic understanding is helpful to understand not only the testing we do, but also the treatments. So this represents just a typical 28-day cycle. And we can think of it kind of in 2 parts. The first part is starts with a period, and that's when all the follicles are little. Okay, all of these potential eggs are waiting for use. And then there are signals of hormones that are sent between 2 places in our brain down to the ovary. It feeds back, and that's what carefully regulates the cycle. So in particular, there's this hormone, FSH, follicle stimulating hormone, that sends the signal to the follicles. And among this group of these little follicles that are waiting for use, one of them is going to grow bigger than the rest. Okay, this is called the dominant follicle. So it takes about 2 weeks typically for that follicle to develop. And this growing follicle is actually making estrogen. Okay, and then mid-cycle, the brain sends another signal called the LH surge, which tells the follicle, okay, time to ovulate, release your egg. So this then prompts the site in the ovary to make progesterone. Okay, and let me see if I can go back. Here we go. So once that egg is released from the ovary, it's swept into the tube, and it's there for a short amount of time, only about 24 hours or so. That's when it's available to fertilize. Okay, but sperm lives longer in the reproductive tract. So if intercourse occurs like a day or two before ovulation, the sperm should be there awaiting the egg's arrival. So with intercourse, sperm is left here. Some of it will travel up through the uterus to the tube. This is where the egg and the sperm will meet. And ultimately, after meeting, they fertilize, becomes an embryo, and then it takes about 5 days until it travels into the uterus, where it will implant and grow. Okay, so several, different components contribute to this. This is a complex process. Every month that a couple is trying to conceive, only about 15% or so are successful. So it can take many months of trying before success is achieved. All right, so in terms of, how do we evaluate or think about fertility, we can kind of break it down into those various aspects that I was just describing. So in terms of the eggs, there are two main considerations. There is the egg quantity, which we refer to as ovarian reserve, and egg quality. Okay, so there's really no direct measurement of quality. There's not like a blood test or an ultrasound that we can do, but we know that it's very closely associated with age. So as our age increases, the ovarian or egg quality rather will decline. There are some measurements, however, for the egg quantity, again, referred to as ovarian reserve testing. So we can check a hormone called AMH, anti-Mullerian hormone. This is a hormone made by cells that surround the eggs. So the more eggs someone has, the higher the AMH, and that will go down as we get older. That doesn't fluctuate throughout a cycle. It really is fairly consistent. So we can check it really at any time in the cycle. However, the FSH is that hormone I was just speaking of that's made by the brain that gets the follicle to grow. And that one we need to draw at the start of the cycle. So we call it day 3. Day 1 is the first day of bleeding. There's some wiggle room. It can be done days 2, 3, or 4, but again, around day 3. We also at that time do an ultrasound. We look at the ovaries with this ultrasound and we count the little follicles. Again, we can't see the eggs, they're microscopic, but we can count the follicles. It looks like a chocolate chip cookie, and all the chips, all these little black circles are the follicles, and we can count them. So we really put these 3 factors together to get a sense, does someone have like a low, average, or high reserve? This is meaningful, but really keep in mind quality is really just as important, if not more, than the quantity. Okay, so the ovarian reserve or the quantity isn't necessarily predictive of ability to conceive. Once we get to a certain point in our reproductive years, our eggs are no longer viable. Okay, they're just no more healthy ones. That tends to happen by our mid to upper 40s, sometimes earlier for others. And then use of donor egg, someone else's egg, is really the treatment of choice. And we offer this treatment as well, of course. So in terms of the quantity, we are born with all that we're ever going to get. We actually had the most before we were born. We had about 6 or 7 million when we were in our mother's uterus. Then by the time we're born, about 1 or 2 million. By the time we hit puberty, about 500,000 or less. And they're just rapidly depleted until menopause. That's when they're all gone. So the average age of menopause in the US is 51. But again, well before this, starting actually in our mid-30s, that's when we see statistically a change start to occur in terms of the egg quantity and quality. All right, good. So let's talk about age and fertility. As we've just been doing, age is like the biggest predictor of success, the age of the egg. The age of the male doesn't matter so much because men are continuously making sperm throughout their lives. But the younger the eggs, the higher the chance of success. Again, this starts to decline in our mid-30s. And even for some earlier than that, about 1 in 2 women will experience premature low ovarian reserve, meaning even before the age of 35, the reserve will start to indicate that it's low. So beyond the eggs, of course, there are other components that are important, including the fallopian tubes. Okay, so this image here is an example of an X-ray film from a hysterosalpingogram or HSG. This test is designed to check the status of the fallopian tubes. So just a moment ago, I explained how the fallopian tube is actually the meeting place for the egg and the sperm. That's the job of the tube, is for the egg and the sperm to meet up. So as you can imagine, if one or both are blocked, especially if both are, there would be no chance for the egg and the sperm to meet. And if one is blocked, that means, we ovulate about 50% from the right, about 50% from the left. So if one side is blocked, then about 50% of the time, there would be no chance of the egg and the sperm meeting. So this test is done by putting a small catheter into the uterus. We instill a little bit of dye that can be seen with the X-ray. And then we see it, we take pictures with the X-ray, we see it fill into the uterus, fill into the tubes, and it will spill out of both ends, indicating they're both open and healthy. So sometimes we see one side might be blocked, it might be blocked close to the uterus, or it might be blocked further away. It might be dilated. So all this will tell us about the health of the tubes. It also gives us an idea, a sense of this space here called the uterine cavity. We can see here, this is a normal shape of a uterus. But we actually do a separate test called a saline sonogram or water ultrasound or sonohistogram. There are a few different names for it, in which the concept is similar. We again put a little catheter in the uterus, but this time we put a little saline and we use an ultrasound to look inside of the uterine cavity and make sure there's nothing that looks like this. This is a big polyp sitting in here. So as you can imagine, if this polyp is sitting in here, it's occupying much of the space inside of the uterus where the embryo would otherwise implant. So we would want to remove that to optimize that space. So we commonly find polyps, often not as big as this one, but we have an easy fix to take care of them. It's called hysteroscopy, where we put a camera in the uterus. We take a good look around the cavity and we're able to remove any tissue that shouldn't be there. And of course, that is done under anesthesia. Okay. And then the sperm, of course, that's the other half of the equation. So we want to assess the health of the sperm. We do this through a semen analysis. There are a few key parameters that we're looking at when we do this semen analysis. We look at the concentration, how many there are. We look at the motility, how well are they moving? And we look at the morphology, how many are normal in shape. Believe it or not, most sperm are actually abnormal in shape. Okay, that's typical. Like we hope to see at least greater than 4% to be normal in order for it to be a normal analysis. So most sperm either can have like two tails, they can have two heads. So there's a head, neck, and tail piece, and any one of these can have an abnormality, and it's thought that abnormal sperm cannot fertilize eggs. So if the analysis is normal, great, nothing further to do in regard to that. If it's abnormal, we typically like to repeat it, right? Because the life cycle of sperm is about close to about 3 months. It's continuously turning over. So we want to take another look because we don't know, was that a good day, a bad day? We want a little bit more of a sense of an average. Okay, so we've just gone over like the different components that we typically evaluate in a reproductive checkup. We could find issues with any number of one of these things. So, just because someone has one identifiable cause doesn't mean there's not a second one. So if someone comes to me and says, well, I don't have regular periods, I'm only getting like 2 periods a year, I know that there's ovulation dysfunction, right? But that still doesn't tell me anything about the tubes or the sperm. So we like to do a full reproductive checkup to really get all of this information so that we can, choose the treatment that will really work best for each situation. So there could be ovulation dysfunction, as I just mentioned, issues with egg quantity or quality. There could be malfactor, endometriosis, issues with the tubes, with the uterus. And, about 20% of the time, all the tests might come back normal. Okay, so this is called unexplained infertility. It doesn't mean there's not an underlying issue, but these are just, some basic tests to assess a really complex process. So the way I think of it is, there's still likely an underlying cause, something that isn't working properly, and that's the reason for the infertility, but we just might not have the right test to detect it. And sometimes as we're going through the treatments, and by the way, we do have even specific treatment for those with unexplained infertility. But sometimes as we're going through the treatments, we actually learn more about what the underlying cause might be. So the treatments can be sometimes, diagnostic as well as therapeutic. All right, perfect. And then, of course, there are other, non-anatomic or hormonal causes. There are, individuals or couples who are electing or trying to build their families who may need outside help with, for example, donor sperm or a gestational carrier or so on. Okay, so once we assess all of these different aspects, then we choose the best treatment for each individual situation. Some examples, though, of treatments can include ovulation induction, often combining with IUI, intrauterine insemination. There's in vitro fertilization. We can freeze sperm, eggs, embryos for fertility preservation purposes. And then there's donor conception, as well as gestational surrogacy. So we're going to review these in a little bit more detail now. In terms of fertility preservation, one increasingly common utilized treatment is egg freezing. So as I mentioned, we're born with this set supply of eggs, and our eggs will never be as young as they are today, right? So sometimes there are situations in which someone might know that they want to have a family, but they aren't ready to start that yet. So a very good way to increase the chances of future success would be to freeze the eggs, because once frozen, they don't continue to age outside of the body. So the way we do this is by giving hormones. It's actually the same hormones I was explaining before, the FSH and a little bit of LH, to help not only one egg, but multiple eggs to develop in a cycle. We then take the eggs out of the body through a minimally invasive procedure called an egg retrieval. And then we freeze the mature eggs. So we use a technique called vitrification, which is very effective at freezing the eggs. There used to be this old technology called slow freezing that really wasn't as good at it. So we were able to freeze sperm and embryos very well, but not as much eggs. But about a decade or so ago, the technology of vitrification really became well proven. And so the experimental label on egg freezing was lifted at that point. So it's being increasingly used. The eggs are stored in storage tanks and really are good indefinitely. There's no expiration. So whenever someone would be ready to utilize them, we would be able to thaw them and then ultimately fertilize them with the sperm to create embryos. And then, of course, being transferred into the uterus to create an ongoing pregnancy. So in terms of intrauterine insemination, IUI, this is often combined with ovulation induction. So this is when someone takes a medication to gently stimulate the ovaries. So not only one egg develops, but maybe two or three. And then we would help someone to ovulate. So we know exactly when that's happening, so we can optimize the timing. And we place the sperm basically inside of the uterus at a specific time. So this is a very commonly utilized treatment, often maybe the first step in the treatment plan. And we know that it often does take more than one try. So it's sort of in a best prognosis situation, works up to about 20% or so per cycle. So again, it often takes more than one try. But if it doesn't work after 3 cycles, then we typically move on to IVF as the next step. IVF is going to be much more successful, more like up to 60 to 70% or so per transfer, depending on the situation. And in this case, it's very similar to what I was just describing with the egg freezing, where the ovaries are stimulated to make many of the follicles grow. We take them out of the body. The difference is instead of freezing them as eggs alone, we then combine them with the sperm. So this image right here is showing ICSI, intracytoplasmic sperm injection, where actually a single normal sperm is being injected into this egg to maximize the chance of fertilization. So it is a bit more invasive in that the medications are given by injection, so tiny needle just under the skin in the abdomen on average for about 10 days or so. Then again, we take the eggs out of the body through that egg retrieval process that is done under anesthesia. So everyone is comfortable, doesn't feel any pain. It's a quick procedure, maybe about 15, 20 minutes or so, often even less. And then we watch the embryos develop in the lab and ultimately would plan for a transfer into the uterus. And again, as I mentioned earlier, there can be all different, ways of building families. There are options of using donor sperm, donor eggs, donor embryo, or gestational carrier. And so depending, again, on each individual situation, after the evaluation, we would review what options are available. So, fun fact, today is actually World Embryology Day. So I wanted to just take a moment to highlight the IVF lab and the embryologists because they really, do amazing work and they're a really critical and important part of the team. So the embryology lab is where the magic happens, so to speak. In our practice, our IVF lab is in our Norwalk location. This is where the IVF takes place, where the egg retrievals, as soon as we drain the fluid from the follicles, it's handed immediately to the embryologist who searches through the fluid, identifies the eggs, separates them into another dish. Later on that day, they fertilize them, the eggs using either standard insemination or ICSI. That's where we, again, handpick a sperm and inject it directly into the egg, as opposed to standard insemination where the eggs and the sperm are left in a dish to fertilize as they would naturally. They perform things such as PGT testing, pre-implantation genetic testing, where they will actually biopsy, remove a small number of cells from the embryo that those cells can then be actually analyzed to see if they're chromosomally healthy. And then the embryo is frozen. So they are the ones who freeze the eggs or embryos or the sperm and also do the thaws when we're ready to utilize them or transfer. And the IVF lab is really an amazing place with really high-tech technology. It's a very exciting place. The world of IVF is quite young, right? The first woman born from IVF is only in her mid 40s. So if you think about how much this technology has evolved, it's really a very exciting field and place. And I think we'll just continue to improve and evolve beyond what it currently is as well. All right, perfect. So, in terms of when you might encounter an embryologist, it would be really at the time of an egg retrieval or an embryo transfer. You would get to meet the embryologist who would be helping with your case that day. All right, perfect. So that is, again, a brief overview of some of the things that we do, the testing, the treatments. So in terms of next steps, we would love to speak further with you to talk more specifically about your situation and help you with your journey. So here are some different QC codes that can help with these various next steps. And I really appreciate you joining me this evening. I'm gonna take a peek at our Q&A. Okay, so if you have any questions, feel free to type them in. None yet. I'll give it another minute or so. If anyone has a question, feel free to type it in the Q&A. Vitamins that can help at each stage. Good question. Okay, so the basic would be a prenatal vitamin, right? So that's important, not only once pregnant, but even leading up to conception. A prenatal vitamin is really like a multivitamin just with extra folic acid. So the folic acid is an important nutrient because if there's a deficiency in this can lead to like developmental issue called a neural tube defect. So we really want the prenatal vitamins started even a few months rather prior to conception. There are many prenatal vitamins out there, many good ones. We're happy, to answer any specifics about the ones that you are taking. And also, I recommend a supplement called coenzyme Q10. This can be used for egg and sperm quality. It's an antioxidant and can help with the sperm quality of both. So I recommend generally those two basics. There are others that can be used in certain situations, but those are the most commonly used ones, I would say. We also, by the way, do think that vitamin D levels are important. We do check everyone's vitamin D level and we'll recommend supplementation if those are low. Generally, 2,000 IUs of vitamin D3 a day is helpful. All right, so next question. Lifestyle factors. How should you balance weight loss when trying to conceive? Is it okay to actively lose weight via reduced calories and increase exercise while trying to conceive? Okay, so another really good question. We do believe that it is important to focus on lifestyle and overall health. I like to, not separate the two in terms of those focuses of achieving a pregnancy and overall health. We can be working at both at the same time. So yes, definitely exercise. You can continue your routine exercise while you're doing fertility treatments. There are certain times in the treatment where we might ask to scale back a little bit on some of the more intense exercise, but both during fertility treatments as well as in pregnancy, exercise is great. In terms of reducing calories, yes, that can be done as long as it's done in a healthy way. We don't want to over restrict. So we have, as I mentioned, the 2 registered dietitians in our practice. They're available to meet with any of our patients, and they're really great sources of information. They'll review in detail what someone is eating, make some suggestions. Really, the model is like a Mediterranean type diet. We want all the different food groups represented. We don't want to over restrict or eliminate all carbs, all sugar. You don't have to be dairy-free, gluten-free, soy-free, etc. If you have a sensitivity, that's a different issue, but good to, again, have all the food groups represented. And sometimes, just to add to that, sometimes, someone might be in a situation where they're not as healthy as they feel they should be entering into pregnancy. Perhaps the focus then becomes on setting aside some time, maybe like 6 months or so, to really focus on weight loss, for example. There are medications like GLP-1 receptor agonists like Ozempic and things like that cannot be taken while pregnant. They have to be stopped like 8 weeks prior to conception. So someone might really, be on a medication like that, focus on the weight loss, and then come off of it and shift towards the fertility treatments. All right, we're going to answer 1 or 2 more. There's a bunch of questions in here. Wow, a lot. So we're going to not get to all these, but I'll answer 1 or 2 more. All right. Let's see. There is a question specifically about inositol as a supplement. So that is a supplement that we commonly use. Inositol is a substance that is made by our own bodies. It's also available in some food sources, and it's available as a supplement. Its primary utilization for us is for women with PCOS. There are many different forms of inositol, specifically 2 forms, D-chiro and myo-inositol, that have been proven to be helpful. Those 2 specific forms in certain amounts and at a certain ratio. So we would recommend also a specific product for that. And that can help with insulin resistance, and it can help cycles become more regular. It's a powder that's absorbed in water, and it's tasteless, and it's taken twice a day, usually with like breakfast and dinner. So we do use that one quite commonly. All right. And okay, let's see. 1 more. A question about a fallopian tube being blocked. So if one fallopian tube is blocked or missing, and there's still one that is open and functional, IVF is not required because we can still hopefully use that open, healthy tube for conception. If both tubes are either blocked or removed or not functioning, then even if it's in place but doesn't look healthy, let's say it's dilated and filled with fluid, that can actually be harmful to the environment of the uterus. And so sometimes we actually remove tubes in order to increase chances of success. I know it sounds counterintuitive, but having an unhealthy tube in place sometimes can be detrimental. So, but if there's one open, healthy tube, we can, perhaps start with something like ovulation induction and intrauterine insemination, hoping that we get an egg to develop on that side with the good, healthy tube. But if someone does not have a functional tube, or after a certain number of failed IUI attempts, then certainly IVF would be the most direct, because we don't rely on the tubes at all, right? We take the eggs out of the body, combine them with the sperm to create the embryos, and then put the embryo in the uterus, and we don't rely on the tubes at all for any of that. So great questions. I'm sorry I can't get to everyone's questions tonight, but thank you so much for joining me. Please feel free to schedule a visit. We can talk about each of your individual situations. And again, thank you for joining me, and have a good rest of the evening. Take care. Bye-bye.